Hello everyone and welcome to QuickMed, where medicine is explained quickly and easily. We will be covering part 3 of our antibiotic series. We have already covered all of the beta-lactam antibiotics in part 1 and part 2, so here we'll cover all the other antibiotics that you need to know. We're going to go over a lot of different antibiotic classes, and this is going to include your macrolides, tetracyclines, fluoroquinolones, aminoglycosides, and along with these, we'll go over vancomycin, sulfonamides, clindamycin, and metronidazole. As we did in the first 2 parts of our antibiotic series, we will go over the different types and what they cover, a summary of everything discussed, and as always, end with a practice question to solidify your understanding. Let's start with vancomycin, which you will hear about a lot. This comes in a PO and an IV version. I want you to think of vancomycin as your gram-positive agent because it covers staph, including MRSA, strep, and non-VRE or non-vancomycin-resistant enterococci. It has virtually no gram-negative coverage. Vancomycin is also used to treat C. difficile, and the preferred route is the oral route of vancomycin because it is not absorbed through the intestinal wall. Because it covers gram-positives like our beta-lactams, it's actually the drug of choice for gram-positive infections in patients who have severe beta-lactam allergy. It's also considered the gold standard for MRSA infections, and so you'll really want to reserve its use for severe MRSA infections. Keep in mind that when there's an antibiotic that has really good coverage, like with vancomycin and MRSA, you really only want to use it for severe infections because you do not want that organism to develop antibiotic resistance, particularly antibiotic resistance to that particular agent because then it limits your treatment options. Now let's move on to our sulfonamides, and this includes Bactrim or trimethoprim sulfamethoxazole, so you'll see why we call it Bactrim instead because it's so much easier to say. Bactrim covers gram-positives like staph, including MRSA, as well as some strep pneumo. It also covers most gram-negatives, but not Pseudomonas. Because it covers MRSA, it is a good choice for skin or soft tissue infections. Also keep in mind that it's unique in that it covers PCP or pneumocystitis pneumonia, nocardia, and toxoplasmosis. Test exam questions like to focus on unique properties of antibiotic agents, especially unique organisms that they cover. Let's now move on to our macrolides, where we have our erythromycin, clarithromycin, and azithromycin, and these come in a PO and IV form. Just keep in mind that these antibiotics are different from clindamycin, even though they all end with mycin. Macrolides cover your atypical organisms, which include chlamydia, mycoplasma, and legionella. So because of this, it's often used with ceftriaxone for community-acquired pneumonia that requires hospitalization. Ceftriaxone is added on because it will cover for strep pneumo, while the macrolide will cover for your atypical organisms. Now we have our tetracyclines, which includes doxycycline, tetracycline, and minocycline. These come in a PO and IV form. Think of your tetracyclines as covering for unusual pathogens like rickettsia, which causes Rocky Mountain spotted fever, as well as Lyme disease. Doxycycline tends to be the preferred tetracycline to use because it has a convenient twice-a-day dosing, whereas the others are more frequent dosing, and it also has less food-drug interactions overall. Doxycycline in particular tends to be a good choice for skin and soft tissue infections because it covers MRSA. Let's now move on to our fluoroquinolones, which include ciprofloxacin, levofloxacin, and moxifloxacin. These all come in a PO and IV form, but because fluoroquinolones have a good bioavailability, it's better to use the PO version when you can. All of these have good atypical coverage. Ciprofloxacin has the best gram-negative coverage of all of the fluoroquinolones, but it has virtually no gram-positive coverage. Because of this, it's not used for community-acquired pneumonia, but it can be used for hospital-acquired pneumonia because it covers for Pseudomonas. But when you're treating for hospital-acquired pneumonia, you'll typically need to use a second agent along with this for broader coverage. In contrast, levofloxacin can be used as monotherapy or on its own for community-acquired pneumonia because it has excellent activity against strep pneumo. You can consider levofloxacin as the respiratory fluoroquinolone because of this. For our aminoglycosides, we have gentamicin, tobramycin, amikacin, and streptomycin, and these come in an IV form. These antibiotics have really good gram-negative coverage and even cover for Pseudomonas, and so they are used for serious gram-negative infections like UTIs or pneumonia. Aminoglycosides don't really have great gram-positive activity except in one instance. Interestingly, using them with beta-lactam antibiotics creates this synergistic effect where it enhances the bactericidal action of both agents against gram-positive bacteria. You'll often see this combination used mainly in the treatment of endocarditis. Let's now move on to our final 2 antibiotic agents that are really good when it comes to anaerobic coverage. We'll start with clindamycin, which as you said is different from your tetracycline class, and this comes in a PO and an IV version. Along with covering for anaerobes, clindamycin is used to cover gram-positives like staph and strep, as well as MRSA. Because it has adequate strep and staph coverage, it can be used to cover for cellulitis. One thing to know about clindamycin is that it causes a high rate of C. diff amongst other antibiotics, and so this is something to keep in mind. Metronidazole, also known as Flagyl, comes in a PO and an IV form. It is the drug of choice for most anaerobic infections. We often use it with other agents at the same time because anaerobic infections are usually part of a polymicrobial infection. It can be used for a wide range of clinical reasons, but here are a few to keep in mind. It can treat bacterial vaginosis or BV, trichomonas, C. difficile, H. pylori, along with other antibiotics and combination therapy, Giardia, and Entamoeba histolytica. Alright, let's summarize some key points that we just covered. We discussed that vancomycin is considered the gold standard for MRSA infections, but other agents that also cover for MRSA include your sulfonamides or Bactrim, doxycycline, and clindamycin. Our macrolides and fluoroquinolones have really good atypical coverage, and think of your tetracyclines as covering some unusual pathogens. Clindamycin and metronidazole have really good anaerobic coverage, but also keep in mind that metronidazole or Flagyl can be used for a wide range of things as well. Alright, let's go through a practice question now. Here we have a 58-year-old man who was brought to the emergency department because of a one-day history of fever, headache, and confusion. He has a history of type 2 diabetes and hypertension, and his current medications include lisinopril and metformin. He appears confused, and he has a temperature of 101.5, blood pressure is 120/84, and pulse is 103. Examination shows neck stiffness, and a lumbar puncture is performed. Gram stain of the cerebrospinal fluid shows lancet-shaped gram-positive diplococci. Which of the following is the most appropriate pharmacotherapy? Alright, so here we have a patient presenting with a fever of 101.5, headache, and confusion. He also has neck stiffness on exam, and all these findings are concerning for meningitis. The lumbar puncture, or LP, shows that there is a bacterial infection, specifically strep pneumo. Alright, so for this question, you really need to know how to treat meningitis. And for young adults and adults less than 50, we empirically treat meningitis with ceftriaxone and vancomycin. So the correct answer choice here is C, but by having a good understanding of antibiotics and what they cover, you can understand why we use these two agents. The thing is, with a severe, life-threatening infection like meningitis, you really want to start treating the patient with the best antibiotic combination that you can. You basically start broad and then narrow down as you go along. Because pneumococcal resistance is becoming an increasing problem, by adding vancomycin, you're ensuring that you're having proper coverage against strep pneumo here. And then once culture results come back and you have susceptibilities, vancomycin can be discontinued as long as ceftriaxone on its own is sufficient. Alright everyone, we hope you found this video helpful. If you did, please make sure to like and subscribe, and as always, good luck studying everyone.